Welcome to this afternoon's late-breaking science session, Building on the Foundations of Treatment, Advances in Heart Failure Therapy. I'm Dr. Don Lloyd-Jones, and I'm pleased to welcome you back to the studio here in Dallas, Texas. This session will cover the latest advances in heart failure therapy, and a little bit later on, I'll be joined by Dr. Minnow Walsh for her commentary as well. Please remember, your questions are welcomed during this session and could be answered live by speakers during that session. Please enter your questions in the box to the right of your video viewer to submit them in real time. And we'll be watching along the session right along with you. So now let's kick it over to the studio to Drs. Clyde Yancey and Dr. Beacom Bozkurt.
Hello, I'm Clyde Yancey, Professor and Chief of Cardiology at Northwestern University Feinberg School of Medicine. I'm thrilled to welcome you to Late-Breaking Clinical Trials Session 5, focusing on advances in heart failure therapy. It's my joy to serve as co-moderator for this session with Dr. Beacom Bozkurt, Professor of Medicine and Cardiology at Baylor College of Medicine in Houston, Texas. And we have our outstanding social media moderator, Dr. Nisrin Abraham from the Inova Heart Institute, Director of Heart Failure Research and a rising star in our field. Let me remind you once again, please submit your questions. We can access those questions via Slido. We would love to have your input as we go forward with this exciting new information. Now, Dr. Bozkurt.
Thank you, Clyde. I'm very happy to present our first speaker, Dr. Stefan Anker from Charité University in Berlin, Germany. His presentation is titled Empagliflozin in Heart Failure with Preserved Ejection Fraction over greater than or equal to 50%. Results from the EMPEROR Preserved clinical trial. This presentation will be followed by discussion by Dr. Minnow Walsh from St. Vincent Health in Indianapolis. Stefan.
Thank you so much for giving me the chance to present here. As you can see, I'm presenting on behalf of the Executive Committee investigators and study coordinators of this trial, and the 6,000 patients almost we recruited into this trial. The EMPEROR Preserved trial was shown as the main result 3 months ago, and you know that we included patients with and without diabetes and heart failure with a preserved ejection fraction for this trial, originally labeled as ejection fractions above 40%. Now, the patients were randomized to empagliflozin once daily, 10 milligram, or placebo. The patients had structural heart disease. The patients basically were followed for 26 months for the primary endpoint of cardiovascular mortality and heart failure hospitalization as a time to first event. When we set up the study, it was clear that many patients were also recruited with the 41 to 49% ejection fraction. That, of course, is heart failure with mid-range ejection fraction and is considered maybe not so much heart failure with a preserved ejection fraction in the true sense. Hence, we created a stratification highlighted here in yellow, and this was for 50% and higher ejection fraction versus all the other patients. This served the main purpose so that in the end we can really portray the results and summarize them for this heart failure with preserved ejection fraction in the true sense, ejection fraction 50% and higher subgroup alone. We will, in this presentation, contrast the results compared to the patients with 41 to 49% ejection fraction and compare them also to the results seen in other relevant studies. So first of all, let me highlight some of the baseline characteristics of the patients with 50% and higher ejection fraction. 4,005 of them were included. They had a mean age of 73 years. Half of them were women, and almost half of them had diabetes. The GFR at baseline was 59, and you can see that 56% of patients had atrial fibrillation. And to the right of it, you see the comparative kind of data for the HFmrEF group. What is really of interest is the baseline therapy of these patients. 79% having a RASI therapy already at baseline, 84% a beta blocker, and even MRAs, 33% and 80% had a diuretic. Going into the main results for this subgroup, here you can see the primary endpoint was reduced by 17%, reaching significance in its own right in this subgroup with a p-value of 0.024. This is the primary endpoint of cardiovascular mortality and a first heart failure hospitalization as time to first event. This was driven by heart failure hospitalization, and you can see here the first heart failure hospitalization in itself was 22% reduced, also significant in its own right. Cardiovascular mortality and all-cause mortality were not significantly reduced, and recurrent heart failure hospitalization was 17% reduced, but also not significant in its own right. You can see here the Kaplan-Meier curves shown. These graphs give the hazard ratio, the p-value, but also the interaction compared to the other groups. You can see no interaction at all to the 41 to 49% group for the primary endpoint. And if you take here cardiovascular death and first heart failure hospitalization, also for those, the Kaplan-Meier event curves. For completeness, here the results for the 41 to 49% mid-range group in itself. The results were, in terms of magnitude, bigger for this subgroup than for the patients with true HFpEF, and reaching significant also for the primary endpoint for first, but also for recurrent heart failure hospitalizations. Now, when you want to explore this further, many people are concerned about the higher ejection fractions. Here, a description of the ejection fraction for the primary endpoint and total heart failure hospitalization within the group of patients with true HFpEF, and split the groups by 5% points and going up to 70%. And for those who are interested in trend tests for p-values interaction, you can see a 0.9 p-value for the trend test in the first primary endpoint result, and for the total heart failure hospitalization, the trend test would be 0.3. I would like to highlight the fact that for patients with 70% and higher ejection fraction, the hazard ratios are well below 1, particularly for those with 65 to 69%, the hazard ratios are well above 1 in this data presentation. Now, with regards to quality of life, I would like to emphasize that both in patients with true HFpEF and those with mid-range ejection fraction, quality of life was similarly improved. Here for the primary focus of the study, the clinical summary score, but this is also the case when you take the total summary or the overall summary scores. There are significant positive results for patients receiving empagliflozin versus placebo in this trial for the population with 50% and higher ejection fraction. Now, it's not all about events and quality of life measured, but also really about symptoms of patients. And here we depict the New York Heart Class changes in the patient with 50% and higher ejection fraction. There was more frequently an improvement and less frequently a deterioration in New York Heart Class. The odds ratio result, if you formally compare this, and this is shown by Javed Butler in his quality of life and symptom specific presentation, is also significant positive for New York Heart Class changes in this population. When you come to mechanistic discussions, vital signs and biomarker results are of interest. And here, again, they are shown for the patient with HFpEF. You can see that glycated hemoglobin in those with diabetes had only a small change, reaching, of course, significance when you talk about thousands of patients, but 0.2% is not much. The hematocrit change is most likely due to a stimulation of erythropoietin production by SGLT2 inhibitors. It is unlikely to be a diuretic effect. There's a very small change in NT-BNP. The geometric mean change is only 6%. Body weight, 1 kilogram down, and the systolic blood pressure only reduced by 1 millimeter mercury. Now, coming to a comparison of this primary endpoint we used, first event of cardiovascular death or heart failure hospitalization, across other trials, and all these other trials used neurohormonal inhibitors, and you can see results in the 4 to 8% range for this subgroup of patients, reaching 17% with empagliflozin. But I would like to note that the results for iPreserve are for patients with 45% and above, and for Paragon are for patients with above 50% ejection fraction. Because of this imprecision, we actually calculated also the results for our trial for patients only with above 50% ejection fraction, 3,500 of them compared to 4,000 in the Paragon trial. And you can see here like-for-like comparisons for the different endpoints with very clear differences showing more significant results for the emperor-preserved population. You may argue that Paragon was an actively compared trial, but I would like to remind everybody that 79% of these patients already at baseline received RASi inhibitors. Now, furthermore, let me summarize. This trial shows that for patients with a 50% or higher ejection fraction, that the guidelines consider the true HFpEF patients. We show that the primary endpoint of cardiovascular mortality and a first heart failure hospitalization is reduced significantly and in a meaningful way by 17%. First hospitalizations are the driver of this, 22% down. Quality of life and kidney function as measured by the slope of change in GFR was also significantly improved. So that leads me to conclude that here we have a successful trial overall, but also a successful trial for the specific population that is now considered the HFpEF population by most recent guidelines with 50% and higher ejection fraction. These benefits, 17% significant for the primary endpoint, also extend to quality of life, to symptoms and kidney function data. And this is, in summary, I think the first large-scale evidence of any drug improving the outcomes specifically for what we today consider HFpEF patients with heart failure and 50% or higher ejection fraction. Thank you so much for your attention.
It's my pleasure to comment on this important analysis of the emperor-preserved heart failure trial. My congratulations to Dr. Anker and his co-investigators for this important analysis. This extends our knowledge of the benefits of this agent, empagliflozin, across the wide range of left ventricular ejection fraction. I think it's really important to underscore the fact that 50% of the patients, the subjects enrolled with LVEF greater than 50% were women. Women are differentially disadvantaged by lack of information on guideline-directed medical therapy, so this is good news for our women patients. The benefits were not attenuated at a higher ejection fraction, as was already pointed out by Dr. Anker, as was seen in the Paragon heart failure trial in particular. The curves separated early, and really important patient-centric outcomes were emphasized. Patients felt better, as was manifested by New York Heart Association functional class measures and also KCCQ scores. So take-home messages from this important analysis. Clinicians who are busy can now refer less to ejection fraction than to what the phenotype of their patient is with regard to whether or not they can use this important therapy. We don't have to stop, reassess left ventricular ejection fraction with echocardiography or other imaging modalities before we decide what we need for our patients. And I think lastly, we have to keep in mind that in many parts of the world, these the SGLT2 inhibitors remain expensive and there are patient barriers to access, and we need to continue to work on that. Thank you.
I would like to thank Dr. Anker and Dr. Walsh for their outstanding presentations, and we'll now turn to our social media editor, Dr. Ibrahim, for potential questions that may be coming from our audience. Dr. Ibrahim, are you able to join us?
So we have a question here from the audience. Which one of the Fantastic Four can we use in patients with HFpEF? And Fantastic Four, I'm assuming the 4 pillars of GDMT in heart failure with reduced ejection fraction. So the question is, which one of them can we use for patients with heart failure with preserved ejection fraction? Dr. Anker?
Well, thank you so much. I can, of course, see the argument. And I would like to emphasize that the current ESC guidelines give now soft recommendation for mid-range ejection fraction patients for RASi inhibitors, beta blockers, and MRAs, not yet for patients with 50% and higher ejection fraction. Physicians are voting with their feet on behalf of their patients and give patients, in many cases, as I've just shown you, 80% RASI, 80% beta blockers, these medicines. And we tested on top of that whether empagliflozin worked. So evidence-based wise, we have, I think, the strongest evidence for SGLT2 inhibitors, but the reality is physicians already give these other medicines.
Fantastic.
With that, I'd like to now turn over to Clyde to introduce our next presenter.
Well, thank you very much. And let me also congratulate Dr. Anker for bringing new information to our attention and helping us better utilize this exciting new class of therapies. We want to continue the conversation about the appropriate use of the SGLT2 inhibitors in the setting of heart failure. And to do so, we'd like to invite Dr. John Spertus to give us his view based on the CHIEF-HF trial. Dr. Spertus is Clinical Director of Outcomes Research at St. Luke's Mid-America Heart Institute. Dr. Spertus.
Thank you so very much. It's really a privilege to be able to present. And today I'm going to be presenting the CHIEF trial on behalf of the steering committee, the site investigators, and the participants. These are my disclosures. So almost a decade ago, the Institute of Medicine really challenged us to think about transforming the clinical research infrastructure in the United States for the conduct of clinical trials and the generation of new evidence, in large part because of the very high cost and delay in conducting trials, the fact that we had low rates of enrollment and retention, and that many other countries could do it faster, cheaper, and more efficiently than we could. And nothing challenged the clinical trial infrastructure like the coronavirus pandemic did. So we sought to do a study of SGLT2 inhibitors in heart failure. And at the time that it was being developed, there was emerging and growing evidence about the survival and reduced hospitalization rates from SGLT2 inhibitors. But there had not yet been much understanding of the health status benefit, which is now just emerging in a number of trials for both HFrEF and HFpEF. Canagliflozin had established benefits for reducing adverse cardiovascular events and heart failure outcomes in patients with diabetes. It had established renal protection in patients with diabetes, but it did not yet have approval for a heart failure indication. And when thinking of approving a drug for heart failure, you either want the intervention to make patients live longer by minimizing progression of the disease, or you want it to make patients feel better by improving their symptoms, function, and quality of life. And so our research question was, does 100 milligrams a day of canagliflozin improve the symptoms of patients with heart failure after 12 weeks of treatment? To measure this, we used the Kansas City Cardiomyopathy Questionnaire, and we used the 23-item version. And this is an instrument that has been exceedingly well validated, is very interpretable, has been qualified by the FDA as a clinical outcome assessment in clinical trials. And we specifically focused on the total symptom score, the frequency and severity of heart failure symptoms. Importantly, as a self-administered questionnaire, the KCCQ can be collected virtually. So we actually designed an entire clinical trial without a single face-to-face visit. And patients were randomized to canagliflozin or placebo. And the primary outcome was the KCCQ, enabling this completely decentralized trial from taking place. The analytic approach to understanding the results of our trial is to look at the change in KCCQ treatment's total symptom score in all patients who participated and were randomized, had at least one dose of study medication, and had at least one post-randomization KCCQ. We used a mixed effects model for repeated measures where the primary focus was on treatment, but because we stratified patients by HFrEF and HFpEF, we controlled for that, the baseline KCCQ, time, and a time by treatment interaction. To support the interpretability, we conducted a responder analysis, and we also examined in different types of heart failure and those in patients with and without diabetes. The conduct of the trial went like this. Sites were selected to identify from the EMR potential patients that had heart failure, and with or without diabetes, and regardless of the etiology of the heart failure, and to invite them to visit a website. Patients would then learn of the trial through the website, and if they were interested and opted in to be screened, they would then have more complete review of inclusion and exclusion criteria by the sites. And then, if eligible, they would download an app through which they would do an electronic consent form with the PI. Study medications and Fitbits were delivered to patients. And then we followed them for 12 weeks of treatment, stopped treatment, and we have an additional ongoing 6-month follow-up. We had originally planned to enroll 1,900 patients, but because of shifting priorities for the sponsor, the study was stopped early at 476 patients. The inclusion criteria were heart failure of any type, sole access to an iPhone 6 or later or a Samsung 7 or later, willing to wear a Fitbit, and a KCCQ score less than 80. And we excluded patients already on SGLT2 inhibitors, those with a history of DKA or type 1 diabetes, and those with severely depressed renal function. This is the consort diagram of 1,333 patients that went to the website and completed evaluation. 50% consented to participate in the study. We removed another 28% because their KCCQ scores were out of range. And of the patients who we ultimately randomized, 476, 28 dropped out immediately without either taking medicines or completing any post-procedure KCCQ scores, leaving 448 patients to be randomized, 226 to placebo, and 222 to canagliflozin. The baseline characteristics were very well matched, with a mean age of 65, 14% Black or African American, almost half women, 59% with HFpEF, and 72% without a history of diabetes. The study operations worked exceedingly well, with us able to validate the eligibility of all patients through claims data, being able to get all patients study drug, over 90% completing greater than 80% of the study medications by self-report. And the follow-up of the KCCQ was extraordinary, over 95 to 98% completion. So the primary results are shown here. And what we observed was a statistically significant difference of 4.3 points at 12 weeks, favoring the canagliflozin arm in blue. You also can appreciate very early separation of the curves. Within 2 weeks of treatment, the patients with canagliflozin were already trending towards improved symptoms compared to placebo. When we did a responder analysis, this is the distribution by clinically important categories of change in KCCQ. And the number needed to treat to avoid large deterioration was 15. And the number needed to treat for a large or greater improvement, moderate to large improvement, was 27. When we looked at subgroups, we found very comparable effect sizes, regardless if the patients had HFrEF or HFpEF, and regardless of whether they had diabetes or not. There were no new safety concerns identified in the study. And so the limitations are that, we did have a reduction in planned sample size. The sponsor stopped the study early for shifting priorities, but importantly, this was done before database lock or any unblinding. And yet the effect size was still strong enough that we were able to detect benefit from treatment. This was conducted during the COVID-19 pandemic. This may have altered participants' usual activities and impacted some of the scales of the KCCQ and also their symptoms. It was a short-term focused primarily on symptoms, so it was not powered for clinical events. And the study's design required access to a smartphone, which could have introduced some socioeconomic biases, but access to smartphones is really markedly increasing and is fairly ubiquitous now. So in conclusion, canagliflozin 100 milligrams per day improved patients' heart failure symptoms. It did so regardless of their ejection fraction or their diabetes status. The effects were observed as early as 2 weeks and sustained out to 3 months. It was started without any patient visits or labs, really highlighting the safety of implementing and instituting SGLT2 inhibitors, particularly in an area of marked increase in telemedicine visits. It also models a new approach to the conduct of clinical trials with much more rapid enrollment and completion than traditional RCTs. It addresses many of the Institute of Medicine's challenges to improving clinical trials. And frankly, this was launched 2 weeks before President Trump shut down the country because of COVID, and it was completed during the pandemic. I would like to thank the sponsor, Janssen PRA, for working with us on developing the platform conducting the trial, for the site investigators for working on such a novel RCT, all the participants, and for Kenzie Ghosh from our institute validating the findings. Thank you very much.
Hi, my name is Dr. Eldrin Lewis, and I am the Chief of Cardiovascular Medicine at Stanford University School of Medicine, and also the Simon H. Sturzer Professor of Medicine. And it's a true pleasure to be the discussant for the Chief HF study. I would love to congratulate Dr. John Spertus for the accomplishments, and also all of the investigators for the accomplishments of the Chief HF trial. These are my disclosures. So as you know, over the last 30 years, there have been tremendous progress in the pharmacologic therapies that we have for management of patients with heart failure. And with this, we've seen a consistent reduction in the overall mortality for these patients, to the point that with the combination of triple therapy, or the 3 standard pillars of treatment, we had over a 60% risk reduction in the overall mortality. And we also know that there are several drugs that have been approved for quality of life and symptoms, for hemodynamic or physical functioning, hospitalizations, as well as mortality and morbidity and reduction of hospitalizations. So the focus is clearly now on both quantity and quality of life. But now there's clearly a 4th pillar for the treatment of heart failure, and that's the SGLT2 inhibitors. We've seen this consistently with improvements in reduction in heart failure hospitalizations and or mortality, and we're also seeing reductions in quality of life, including the DAPA-HF study, EMPEROR-Preserved, EMPEROR-Reduced, and DEFINE-HF, consistently showing between a 1.5 to about a 4.8 difference in comparison to placebo. As you have just seen, the Chief HF study has now added to this, and quality of life was the specific quality of life measure. And with the quality of life measure, we should also just highlight some of the strengths and the limitations. So certainly for this study was well designed and specifically targeted the assessment of symptoms and exercise capacity. It was well designed and conducted, and I would emphasize no face-to-face visits and no safety labs, but yet there were no real safety concerns. Because of this, there was a diversity of participants, including 14% Black, 45% female, and 59% HFpEF, with excellent follow-up with 98% completion, and the responder analysis was helpful for decision-making. The remote assessment using standard cell phones, and I really loved the entry criteria for the KCCQ. The limitations were mainly the 12-week follow-up without the ability to check for enduring effects. The 6 and 9 months effects will be unblinded, and only 476 participants were actually enrolled, and we excluded the few deaths. But we clearly saw benefit with canagliflozin. So, in summary, as we treat patients and we try to improve their disease burden and transition them to optimization, there's now a growing body of evidence that SGLT2 inhibitors have improvements in outcomes. There's a need to assess persistence of the improvement in quality of life long term, and we must always balance cost versus a benefit and add quality of life in addition to the prevention of progression of disease. Thank you.
Thank you, Dr. Lewis. Dr. Abraham, are there questions that have come forward from the audience?
There's a question for Dr. Spertus. So, Dr. Spertus, do you think we are ready for decentralized trials in heart failure? Are there any health tech trials in heart failure that look promising?
So I think we absolutely are ready for decentralized trials. There are several features that are really important to think about when doing such a trial. First of all, we were benefited by a wealth of data about the safety of SGLT2 inhibitors. And if there are real safety concerns, then I think it's very risky to not have in-person visits with patients. Secondly, the design of the trial, focusing on quality of life as the primary outcome, was one of the key opportunities we had to be able to conduct this completely virtually. And so I think, really it models a new strategy. And there are a lot of interventions and a lot of trials, both pharmacologic, but also altering the way in which we deliver care, test new strategies and protocols, other types of psychosocial and educational interventions that would lend themselves very well to this type of study design. And I hope that we'll see many, many more of these to accelerate the generation of good evidence upon which we can continually evolve and improve our practice.
Well, Dr. Spertus, let us add our congratulations again to you. And Dr. Boskert, let's continue the flow of this great clinical science.
Thank you, Clyde. We're continuing with the SGLT2 inhibitors theme, and it's my pleasure to introduce Dr. Adrian Worz, who is going to be presenting the results from the efficacy and safety of empagliflozin in hospitalized heart failure patients, the main results from the EMPULSE trial. Dr. Worz is the professor of cardiology at University of Groningen in Netherlands, and his presentation is going to be followed by Professor Nancy Schweitzer, who is the director of the Sarver Heart Center at University of Arizona. Dr. Worz?
Thank you, Dr. Boskert. Ladies and gentlemen, it's my great pleasure to present to you the main results of the EMPULSE trial on behalf of the executive committee who is listed on this slide. EMPULSE was a randomized placebo-controlled trial on empagliflozin in patients hospitalized for acute heart failure. These are my disclosures. So EMPULSE could be considered as the missing link. We have seen also today, but also in the last 2 years, that SGLT2 inhibitors have beneficial effect in patients with chronic heart failure, irrespective of whether they had diabetes or not, and both in patients with heart failure with reduced ejection fractions, such as in the EMPEROR reduced and DAPA-HF, as well as in preserved ejection fraction, as we have seen today also in the EMPEROR preserved trial. Now, SOLOIST was a semi-acute heart failure trial, but was only performed in type 2 diabetes and was presented last year at this meeting. Now, EMPULSE is unique in the way that it is purely a trial in hospitalized patients for acute heart failure, either with HFrEF or HFpEF, with or without type 2 diabetes. Patients were eligible for the trial when they were hospitalized with the primary diagnosis of acute heart failure, both de novo heart failure or decompensated chronic heart failure, regardless of ejection fraction or diabetes status. Patients were randomized within 1 to 5 days after hospital admission at a mean of 3 days after stabilization, but still in hospital. And stabilization criteria were no signs of hypotension, no increase in IV diuretic dose or IV vasodilators in the last 6 hours, and no IV inotropic drugs within the last 24 hours. And the natriuretic peptides levels needed to be elevated. Now, patients after randomization were treated with placebo or empagliflozin oral dose of 10 milligrams per day. And they were treated and followed up for 90 days. The primary endpoint was a composite of death, number of heart failure events, time to first heart failure event, and change from baseline in KCCQ total symptom score after 90 days of treatment. And the primary analysis was assessed by a win ratio, which needed a little bit more explanation. So what happened is the computer randomly picks one patient out of the placebo group and one patient out of the empagliflozin group and starts comparing those patients. It first looks whether one of the patients had died. If one of the patients had died, the winner is in the other group. Then if there was a tie, it went to see whether there was a heart failure hospitalization. If there was in one group more than in the other group, then there was another winner. If there was a tie, it looked at the time to heart failure event. And then if there was a tie, it finally looked at a 5 points or greater increase in KCCQ score. So in the end, it was either placebo was the winner, there was either a tie, or empagliflozin was the winner. Now here you can see the baseline characteristics of the trial. 265 patients were randomized to empagliflozin and 265 patients to placebo. Mean age of the patients was 70 years old. 1/3 of the patients was female. Almost half of the patients had diabetes. 1/3 of the patients had an ejection fraction above 40%. And also 1/3 of the patient had acute de novo heart failure. And please look at the KCCQ total symptom score at baseline, which was about 38, which is very low, indicating very severely diseased patients. This is the primary endpoint of the study. And from the box on the clinical benefit on the top, you can see that in 53.9 of the cases, or percentage, empagliflozin was the winner, versus 39.7% placebo was the winner, and 6% there was a tie. And this yielded a stratified win ratio of 1.36 with a p-value of 0.054. In other words, patients treated with empagliflozin were 36% more likely to experience a clinical benefit compared with patients on placebo. And if we look at the crude percentages of death and heart failure event on the right bottom side of the slide, you can see that empagliflozin, there was 4.2% died versus 8.3% in placebo. There was 10.6% of patients who had a heart failure event in the empagliflozin group versus 14.7% in the placebo group. Now, if we look by subgroup, we can see that the effects of empagliflozin were markedly consistent throughout each of the subgroups, in particular those with de novo versus decompensated chronic heart failure, both in those with or without diabetes, and those with lower or higher ejection fraction than 40%. Now, if we then move to the secondary endpoints, like the change in KCCQ total symptom score, we can see that empagliflozin increased the KCCQ TSS with a mean of 4.5 points compared to placebo with a p-value of 0.03. If we then look at the more traditional endpoints, time to cardiovascular death of heart failure event, we can see that empagliflozin reduced this event with 31% with a non-significant p-value of 0.10. But if we look at the time to all-cause death or first heart failure event, we can see a 35% reduction with empagliflozin with a statistically significant p-value. Then if we move to safety, we can see that empagliflozin had a very benign safety profile. Any adverse event occurred in 70% of the empagliflozin patients versus 77% in placebo-treated patients. Any serious adverse event occurred in 32.3% of the empagliflozin patients versus 43.6% in the placebo patients. Now, the adverse events of special interest, for example, acute renal failure, occurred in 7.7% of empagliflozin and 12.1% in placebo. Genital infections were very rare, occurred in 3 patients in empagliflozin and 1 placebo patient, and volume depletion and hypotension and confirmed hypoglycemia were equal in both groups, and of note, there were no cases of ketoacidosis reported. Body weight differed after 90 days in the sense that empagliflozin reduced body weight by 1.5 kilograms, which was also a statistically significant difference. And finally, if we look at changes in renal function from baseline to day 90, we can see that there was an initial drop of approximately 2 milliliters per minute in the empagliflozin group, which went back to normal again after 30 days and 90 days. So in conclusion, initiation of empagliflozin versus placebo in patients hospitalized for acute heart failure resulted, first of all, in a significant clinical benefit within 90 days. There were fewer deaths or heart failure events. We saw an improvement in quality of life. We saw a greater reduction in body weight, and we didn't see any safety concern in this very vulnerable and sick patient population. So this manuscript is now accepted for publication in Nature Medicine. And with that, I would like to thank the MPulse Executive Committee, the national coordinators, Data Safety Monitoring Board, trial operations, investigators, and particularly our patients. And with that, I thank you for your attention.
Hi, I'm Nancy Schweitzer from the University of Arizona. I, of course, must begin by offering profound congratulations to Dr. Voers and the MPulse investigators. The exciting data we have just seen fill an important gap and are clearly practice-changing. Few therapies have been shown to impact the course of those hospitalized with acute decompensated heart failure. These very impressive data demonstrate effective in-hospital initiation of empagliflozin, an SGLT2 inhibitor, in a very ill group of patients with acute decompensated heart failure. The treatment was very safe and had positive effects on a combined endpoint incorporating death, rehospitalization, and heart failure symptoms, regardless of ejection fraction. In the limited time allowed for discussion, I would like to emphasize the critically important fact that in MPulse, initiation of study drug occurred regardless of background therapy. The vast majority of HFrEF trials have added therapies to existing regimens, leading practitioners to be hesitant to break from sequencing of medications dictated by clinical trials history and not science. Because patients in the MPulse trial could be enrolled with a new diagnosis of heart failure, they were by definition not all on chronic guideline-directed heart failure therapy. Nevertheless, such patients benefited equally from this study intervention. This is crucial as it tells us these drugs have immediate and important effects and should not be withheld while other drug classes are initiated and optimized. This conclusion from MPulse has implications beyond the population with acute decompensated heart failure. Seeing and hearing the results of the MPulse trial, of course, raises several questions. One question I am eager to have answered is the impact of the early start of empagliflozin on other drug therapy. In particular, as renal function does transiently worsen in these patients prior to stabilization, is initiation or uptitration of other guideline-directed medications affected? Were there differences in discharge medication regimens between the two arms of MPulse? Finally, I would be remiss if I did not at least mention my distress that enrollment of women seems to have stagnated in the mid 30% range in heart failure trials. Because MPulse was performed agnostic to ejection fraction, I had hoped we would see higher enrollment of women. I am hopeful that the totality of evidence for SGLT2 inhibitors across populations will provide enough data to make conclusive statements about efficacy in underrepresented groups. Nevertheless, I urge my colleagues, the community of clinical trialists and trial sponsors, to start incorporating truly effective enrichment strategies in trial design in order that we can assess drug efficacy in multiple groups at trial conclusion and see enrollment numbers change going forward. The AHA is sponsoring just such efforts, and I applaud them. Again, Adrian and colleagues, my most sincere congratulations. This is a really impactful trial. Thank you.
I would like to thank Dr. Adrian Voers for this outstanding trial results that completes the last missing link in the treatment of heart failure continuum, and Dr. Nancy Schweitzer for her illuminating discussion. And now we're going to turn over to Dr. Ibrahim for some questions from our audience. Maybe we have time for 2 questions, Nesreen.
So lots of questions. The first question is, can you articulate the regional difference in benefits between Asia versus Europe and the American cohorts? And then second, how sick can a patient be to start an SGLT2 inhibitor in acute heart failure? Is there a group of patients that you would exclude from starting in the acute phase?
First of all, there might have seen a small regional difference. First of all, there was a very small group recruited in Asia, so the confidence intervals are very wide, and the p interaction is non-statistically significant. So I think this is a chance finding. The second question is very interesting and very important. How early can we start? This study started treatment from 24 hours on to day 5, and with a mean of 3 days. We have done a pilot trial and response in the past, a smaller trial where we started within 24 hours, also without safety concerns. So it looks like there is hardly any effect on blood pressure. There's only a small effect on renal function, and there were no serious side effects seen. So from this trial, we must say it's safe at least from 24 hours on. And I hope maybe in the future there will be trials that start to give it maybe at an earlier stage within the first 24 hours after hospital admission.
If I can ask Adrian, though, there were blood pressure requirements for initiation, were there not?
Yes, so patients need to be stabilized, and blood pressure was not allowed to be either below 100 millimeters of mercury or symptomatic hypertension.
Well, Dr. Voorhees, Dr. Schweitzer, thank you very much for the discussion of a very important trial, Impulse, expanding our scope of knowledge using the SGLT2 inhibitors. Let's pivot to the final but very important presentation in this late-breaking trial of excellent clinical science. The presenter will be Dr. Emerson Perrin, presenting the DREAM Heart Failure trial results. Dr. Perrin serves as the director of the Center for Clinical Research, director of the Stem Cell Center, and medical director of the Texas Heart Institute. The commentary will be given by Dr. Larry Allen, associate division head for clinical affairs and cardiology, medical director of advanced heart failure at the University of Colorado. Dr. Perrin, please begin.
Thank you. It is my great privilege to present the results of the DREAM-HF trial on behalf of the DREAM-HF trial investigators. My disclosures. The DREAM-HF trial is a multi-center, randomized, double-blind, sham-controlled, events-driven trial of mesenchymal precursor cells in HFrEF. The sponsor was Mesoblast, and I'd like to acknowledge my co-PI and the co-chairman of the steering committee, Dr. Barry Greenberg from UCSD. The co-chairs of the clinical endpoint committees were Dr. Solomon and Scali, and the chair of the data monitoring committee was Dr. Jean Rouleau from the Montreal Heart Institute. The DREAM-HF trial was performed across 51 sites in the US and Canada, and there consisted of a group of blinded heart failure investigators and unblinded interventional investigators. The top 5 enrolling sites are listed on this slide, and I would like to thank all of the investigators for their outstanding work on this trial. Mesenchymal precursor cells are allogenic STRO1, STRO3 positive cells that are immunoselected from the human bone marrow. Preclinical studies suggest that MPCs have anti-inflammatory, immunomodulatory, and pro-angiogenic effects in ischemic and non-ischemic cardiomyopathy models. We performed the first in-human transendocardial injection of mesenchymal precursor cells in a patient with ischemic cardiomyopathy approximately 15 years ago. And in 2015, we published the results of a phase 2 study that suggested that MPCs may reduce heart failure-associated events and adverse ventricular remodeling in patients with persistent HFrEF. Innate and adaptive immune response, along with inflammation and parainflammation, are at the core of the pathogenesis of persistent heart failure, reduced ejection fraction. Inflammatory type macrophages, depicted here as M1 in brown, produce cytokines such as TNF-alpha, IL-1 beta, and IL-6. MPCs are activated by these cytokines and in turn produce growth factors, proteins, immunomodulatory enzymes that result in a polarization of macrophages to an M2 healing type, shown in green. Ultimately, the result of MPC activation in the myocardium is a decrease in inflammation locally in the heart and at the level of the systemic vasculature. with reduction in apoptosis, induction of cardiac microvascular networks, and reversal of endothelial dysfunction. Although this is a very attractive therapeutic target, previous trials of anti-cytokine therapy targeting TNF-alpha have failed. Of note also is that ILS, the soluble portion of ILS, induces CRP production in the liver, as shown in the slide. Key inclusion criteria were chronic heart failure of ischemic or non-ischemic etiology and patients with class 2 or 3 symptoms, LVEF of equal or less than 40% by echocardiography, and patients were enriched, both class 2 and class 3, to have either prior heart failure hospitalizations within the 9 months prior to enrollment or elevated biomarker of NT-proBNP. Patients with recent unstable, acute, or decompensative events were excluded. The single index therapeutic procedure was performed in the catheterization laboratory. Patients randomized to sham control had arterial access and underwent LV angiography and a scripted verbal-only procedure of appropriate duration. Patients randomized to receive MPC therapy after LV angiography underwent electromechanical mapping, as you can see in the slide, with the NOGA system followed by targeted transendocardial injections to pre-specified areas of intermediate unipolar voltage thought to represent viable but inflamed myocardium. On the right is a completed NOGA map from one of these patients with 20 individual injections shown in the black dots. The consort diagram shows that 1,167 patients were screened and 565 patients randomized. Of those 537 patients constituted the as-treated population, with 276 receiving sham control and 261 MPC transendocardial injection. At the end of the trial, we had 100% vital status determination defined as alive or dead for the entire ITT population. There were no differences between the sham-controlled and treated groups in relation to demographic and baseline characteristics. Note the distribution of etiology of heart failure, functional class, and that over 80% of the patients had ICD or CRTD. Baseline cardiac medications were consistent with contemporary guideline-directed medical therapy between 2014 and 2019. The mean left ventricular ejection fraction was 28%. The primary endpoint of recurrent non-fatal decompensated heart failure events was not met. When the primary endpoint is missed, the rest of the findings are considered hypothesis generating. This does not mean post hoc. I want to emphasize that all secondary endpoints that I will present were pre-specified in the protocol and statistical analysis plan. The analyses were also pre-specified in the protocol and statistical analysis plan. The triple endpoint of cardiac death, non-fatal MI, or stroke was post hoc, but not the individual components which were pre-specified. The risk of non-fatal MI or stroke was significantly reduced in the MPC-treated patients when compared to sham controls in the overall population. The top panels show time to first event Kaplan-Meier curves in all treated patients on the left and class 2 and 3 patients in the middle and right. There was a significant reduction of 66% in class 2 and 65% in class 3 in non-fatal MI or stroke. The bottom panel shows forest plots for recurrent events, which were normalized for follow-up time because of the difference in follow-up in class 2 and 3. This shows a consistently significant effect of MPCs on non-fatal MI or stroke, with rate reductions of 69% overall and 71% and 68% respectively in class 2 and class 3 patients. Risk of cardiac death was not reduced in the overall population, but was significantly reduced by 57% in class 2, but not in class 3 patients. The bottom panel, which is again normalized for follow-up, shows a consistently significant 58% reduction of risk of cardiac death in class 2 patients, but not overall or in class 3. Using a baseline plasma high sensitivity CRP of equal or greater than 2 as an indicator of systemic inflammation, we performed a post-hoc analysis to assess the effect of MPC treatment on a composite outcome of cardiac death, non-fatal MI, or stroke in patients with and without elevated inflammation. The left panel shows the composite of cardiac death, non-fatal MI, or stroke in the entire as-treated population. There's a significant risk reduction of 33% in MPC-treated patients. When analyzed according to high or low high sensitivity CRP, shown in the middle and right panels, it becomes evident that the benefit of MPC therapy lies almost exclusively in the patients with inflammation, with a 45% reduction of cardiac death, non-fatal MI, or stroke in those patients. There was no benefit of MPC therapy in patients without inflammation, as shown in the right panel. Let me go back. Placed the wrong slide set here, so I apologize for the interruption. In terms of safety, treatment emergent adverse events and serious adverse events were similar in MPC-treated and control patients. MPC administration did not elicit clinically meaningful immune-related responses in any patient. Transendocardial delivery of cells was safe. There were no complications associated with LV angiography, and one patient had an LV perforation, which occurred during LV mapping for an incidence of 0.4%. In conclusion, transendocardial delivery of 150 million MPCs was safe and did not elicit any clinical meaningful immune-related responses. MPCs did not reduce cumulative recurrent non-fatal decompensated heart failure events in patients with persistent HFrEF. Over a mean follow-up of 30 months, a single MPC dosing procedure added to guideline medical therapy significantly reduced non-fatal MI or non-fatal stroke, cardiac death in NYHA class 2 but not 3 patients, and a composite of cardiac death, non-fatal MI, or non-fatal stroke. Benefits of MPC therapy were most evident in patients with baseline inflammation. Thank you very much.
It's my pleasure to comment on the DREAM heart failure study. And I want to congratulate the investigators on the enormous amount of work that went into this study. I have no direct conflicts of interest. So what did we know before this study? First, heart failure remains a progressive, deadly disease despite the therapeutic advances that we discussed earlier in this session. Second, stem cells offer hope through a range of scientific approaches to potentially cure the underlying disease. And finally, enthusiasm for stem cells in heart failure has been tempered in recent years, with studies showing very small changes in left ventricular ejection fraction, a failure to demonstrate improved health outcomes in patients, and unfortunately, a fair amount of scandal. So within this context, the DREAM investigators set out to give us the right study design to find a positive answer. There are a number of advantages to their approach. First off, they looked at a heterogeneous population of ischemic and non-ischemic heart failure with reduced ejection fraction. These patients clearly had heart failure with symptoms of heart failure, including IV therapy in the last 1 to 9 months, and about 2/3 of the patients having New York Heart Association functional class 3. This was a very large study with 537 patients from 51 sites going through this very involved study protocol that included sham study for those on placebo with blinding of both patients and the heart failure investigators. And finally, we look importantly at clinically meaningful outcomes, including heart failure, major adverse cardiac events. What did we learn? Well, first, the primary outcome of heart failure MACE was neutral. In fact, the hazard ratio was 1.2, so there was no trend in favor of the treatment. The secondary primary outcome of terminal cardiac events was also neutral with no trend in favor of the intervention. And this secondary number 2 event of all-cause death was neutral with no trend. So just in case you are confused, this was a neutral trial with no trend. What did we learn? The tertiary findings here are interesting, but subgroups with significant benefit don't necessarily make sense. This was driven by non-fatal MI and non-fatal stroke, but there was no effect on heart failure hospitalization or other clinical outcomes that we follow in heart failure. Second, it was proposed that this would help with inflammation, and it was better in patients with high CRP, but again, prior studies of TNF inhibitors where this was the focus were not beneficial. And then finally, they did see a bigger benefit upstream in New York Heart Association Class 2 patients, and this is a consistent theme that we've seen in SCUD-HF2, REHAB-HF, and other studies. So how will it change practice? Well, let's keep up the investment. Heart failure remains a deadly disease. Sacubitril and SGLT2 stories show that we can still add meaningfully to therapy. Failure of one approach does not condemn the entire field. Patients should understand that stem cells remain experimental. Study participation in these studies helps science. People should do it, but the current treatments are unlikely to help them individually. And finally, we should double down on guideline-directed medical therapy. Let's start with high-value care in our patients who come to us seeking to feel better. MRA use is still less than 50% in eligible patients. Thank you.
Well, let me thank Dr. Perrin for presenting the results of DREAM-HF and Dr. Allen for brilliant discussion. Dr. Ibrahim, we have time for one important question. Please select the one best question you'd wish us to answer.
I will select an SGLT2 inhibitor question a lot of people are asking. And Dr. Walsh, I don't know if you can comment on this. If there's only a reduction in heart failure hospitalization in patients with HFpEF treated with SGLT2 inhibitors, is that enough to support the use of SGLT2 inhibitors in all patients with HFpEF?
Dr. Allen, why don't you take that, and I'll be happy to comment as well. If you missed it, yeah. I think that is sufficient. This is the first time we've had an evidence base that supports with any strength of data that we can uniquely change the natural history of heart failure with preserved ejection fraction, although we're trying to redefine exactly what that means and at what threshold of ejection fraction. But to know that we can attenuate morbidity, attenuate hospitalization, this is a meaningful outcome. And though we still need to find something that saves lives, we cannot overlook the fact that we can improve morbidity, and we cannot overlook the fact that quality of life is better as well. Let me close out the DREAM-HF discussion with just a brief question to Dr. Perrin. I mean, we've seen the data, we've seen the good faith effort. For over 2 decades, we've been pursuing regenerative therapy, largely with your energy. What's next? What do we do now?
Well, I think actually the DREAM-HF trial turns a page on stem cells and heart failure, because now we understand a clear mechanism of inflammation. We have cells that are anti-inflammatory. And we heard mentioned that TNF-alpha trials have failed. Well, these cells are activated by cytokines, and they put out many cytokines. And so we understand now that the mechanism of inflammation is one that does not address congestion, as we see in the SGLT inhibitors, but one that addresses the core of what keeps heart failure going, which is this smoldering inflammation. And when we see a decrease in stroke and MI, we see that the immune process, which is that of atherosclerosis and rupture of atherosclerotic plaque, is also impacted by the anti-inflammatory systemic effect of these cells. So actually we're very excited because we have a lot to pursue now, and I think we'll be very focused in exploring what we did see and not using an endpoint of congestive recurrent events of congestion, but an endpoint of mortality, stroke, and MI.
So it sounds like turning the page is the right reference, but the important page that we're turning is the necessity to further explore science. to understand about regenerative therapies, to understand how inflammation, as complex as this is, impacts ventricular function, to understand the mechanism of action of SGLT2 inhibitors. And a very important set of results like this is great that we can raise new scientific questions. Dr. Bhaskar, can you close us out?
Thank you, Clyde. These are exciting times for heart failure. So I would like to thank my co-moderators, Drs. Yancy and Ibrahim, our presenters, our discussants, our participants. And we look forward to seeing you at our next discussion, which is going to be at 5:15. You will have ample opportunity to ask further questions to our trialists at the Meet the Trial session. And I would like to now hand it back to Drs. Mino Walsh and Dr. Lloyd Jones at the main desk for commentary.
Hi, I'd like to welcome you to this rebroadcast of this important late-breaking session concerning advances in heart failure therapy. I'm Mark Drasner. I'm the clinical chief of cardiology. It's my pleasure to be one of the two commentators. And I'd like to welcome Dr. Sakata, and I'll let him introduce himself and provide his commentary. Dr. Sakata?
Yes, thank you very much. Thank you very much for this opportunity. I'm very honored to be here. I'm Yasushi Sakata from Osaka University, Japan.
And please go ahead and provide us your commentary.
I like the way that felt there, Tammy. That felt a lot better using that Q&A slide.
Go ahead, Dr. Sakata, please.
Okay, so today we have 4 very important trials. And first of all, I like to congratulate on all of the investigators and the participants in this trial. So all of these trials are very beneficial, provide beneficial information for the Pacific Rim and the Asian doctors and the patients. So I'd like to have some comment over each trials. So first of all, I'd like to comment on the Emperor Preserve trial. So this is a sub-analysis of Emperor Preserve trial. And this time, investigators focus on the true HFpEF patient with more than 50% of LV ejection fraction. The results are consistent with overall results. The patient with more than 50% of LV ejection fraction received clinical benefits on the heart failure MACE and the quality of life. These results are important for the Asia Pacific region because we will have ultra very high age societies, and we need to expect a steep increase in the HFpEF patients. So these data are very beneficial for the treatment with our patient. But I think we still need to consider why the patient with 60 to 65% of LV ejection fraction received no benefit. So I think we still need to evaluate the ejection fraction using the echocardiography or something like that. So next, Chief HF trials. I'd like to give a brief comment on this trial. So this trial used interesting enrollment and the data collection from study subjects, and it used a smartphone and no face-to-face visits. The sample size was not enough because of the sponsor shifting priorities, but this is a decentralized trial, and it opens a new approach on patient-centered clinical trial, even in the COVID-19 pandemic. So I think the ASEAN and the Pacific Rim countries will introduce this new approach. And the next, the very important trial, the EMPULSE trial. This trial included the 530 patients with a primary diagnosis of acute decompensated heart failure, regardless of the ejection fraction and the diabetic states. So they received 10 milligrams of empagliflozin and placebo. The trial used a win ratio to evaluate the composite outcomes of all-cause death and heart failure events, quality of life improvements at 90 days after administration. The results are very exciting. The more patients who are treated with empagliflozin experienced a clinical benefit compared with a placebo using a win ratio method. So this clinical benefit was consistent in the patient with de novo and the decompensated chronic heart failure both. So this research has provided a new therapeutic target for SGLT2 inhibitors. However, we need to focus on the difference in clinical benefit among regions. Unfortunately, Asian region looked better in placebo group than in the treated group. So this, of course, this study included a very small number of Asian patients, and the authors said that there was no interaction among the regions. So they say that this might be a kind of chance events. So I have no idea about the reason of this difference, and we need further information of some analysis. But I speculate that this difference may be associated with longer hospital stay. We have averaged 20 days of hospital stay in a patient with acute decompensated heart failure in Japan. So composite endpoint is at 90 days after administration. And so that's why we have longer time for decondition. I don't know, but so this difference means SGLT2 inhibitors contribute to the decondition by a kind of diuretic effect in acute heart failure patients. So finally, I have a comment on the DREAM-HF trial. So previous trial of stem cell therapy showed some positive results, but at the same time, the trials caused some issues to be solved, like non-clinical beneficial outcomes or small number of enrollment or some scandals. So to overcome these issues, DREAM-HF trial aimed to evaluate the efficacy and the safety of mesenchymal precursor cells, MPCs, in chronic heart failure. MPCs are expected to provide a polarization of pro-inflammatory type 1 macrophages to anti-inflammatory type 2 macrophages to prevent LV remodeling. So I examined the protocol, and this trial used a joint frailty model, which picks up non-fatal heart failure MACE before terminal cardiac events. And this method, I think, that increased the number of the events and provides a time and cost-saving effects in the clinical trials of particularly in the advanced heart failure therapies. However, as you can see, the result are neutral and no trend. So I'm a little disappointed, but we can find a very small hope in this study. So the patient with NYHF class 2 has a benefit from this treatment. So that means if we can do early therapy using the stem cells, it might be promising, but I don't know. But this trial is not that did not include Asian patients, but maybe if we can do a cost saving to make these type of cells, it may be used in the patient with an earlier stage. That's my comment. So how do you think about these trials on and what's the impact for the global audience, Dr. Dressler?
Thank you, Dr. Scott. And I too am very excited to participate in this commentary and want to congratulate the investigators. This is really a series of important trials that advance our knowledge. So first, for Emperor Preserved, the issue was in that trial, as Dr. Anker discussed, is that it included both patients with mildly reduced EFs and those who had what we would really call HFpEF. And so this sub-analysis now really demonstrates that the efficacy of a therapy does extend to those patients who really do have HFpEF, and not only in terms of reducing heart failure hospitalization, but also quality of life and New York Heart Association classification. So given the paucity of therapeutics in HFpEF, this does support a change in practice, in my opinion. We, of course, are awaiting the results of the DELIVER trial, DELIVER looking at dapagliflozin in patients with HFpEF, both to confirm the benefits of SGLT2 inhibitors in that population. And also, I think it will be interesting to see whether dapagliflozin has an impact on cardiovascular mortality in patients with HFpEF and DELIVER, which would perhaps set it apart from empagliflozin in EMPEROR Preserve. We'll have to wait and see that trial to see that potential benefit. I'm very excited about MPULSE, as you were, Dr. Sakata. And this trial is supporting the possibility that these remarkable agents may also be effective in acutely decompensated heart failure. We had a hint of that in SOLOIST, but sotagliflozin, which is both an SGLT1 and 2 inhibitor, was started on the day of discharge or shortly thereafter discharge, whereas this now is really looking at with during the index hospitalization, 24 hours after or up to 5 days after being in the hospital. And it demonstrated important clinical benefits. It's important that the patients to be enrolled had to have a systolic blood pressure greater than 100. That's important for us to remember as we're talking about implementing this therapy. And I agree, the endpoint was very interesting, this win ratio, where they hierarchically assessed whether there was first mortality, then whether there was heart failure hospitalization, then ultimately quality of life by KCCQ, really putting all together mortality and morbidity in one endpoint. So I thought that was very interesting. And also caught my attention was the 50% reduction in mortality through 90 days, down from 8 to 4% essentially. And then also an absolute reduction of heart failure hospitalization by 4%. Very impressive data, as well as the quality of life improvement of almost 5 points in the KCCQ, which is felt to be clinically meaningful. And then further, it was irrespective of diabetic status and irrespective of EF status, mirroring the chronic situation. I think there's a lot one can talk about with MPULSE. It's a very exciting trial. I think the 2 points I'll emphasize first is that it did enroll patients with de novo heart failure, not just acutely decompensated acute on chronic heart failure. And I think that it has important and potentially profound implications as we think about how do we sequence these medications in patients with heart failure. That's probably the most common question now for quadruple therapy. Do we need to sequence them? When should we start them? Can you start an SGLT2 inhibitor before beta blocker and ACE, et cetera? And I think these data point to that question and have important implications. And I would also say that acutely decompensated heart failure has even been more challenging than HFpEF. HFpEF itself was challenging, but acutely decompensated heart failure has been even more difficult. And so these data and those by SOLOIST suggest that SGLT inhibition will be an important component in our therapeutic for patients with acutely decompensated heart failure. So I think this is an extremely important trial. And then finally, I want to comment on CHIEF-HF. The extension of data showing SGLT2 inhibitors and quality of life. This trial was interesting in that regards, but we had pretty solid data both in HFrEF and in HFpEF. We heard from EMPEROR Preserved earlier. The Preserved HF was published in Nature Medicine last month showing dapagliflozin. We had pretty good data already in terms of SGLT2 inhibition, in terms of improving quality of life. But what was really interesting was the study design here, is that there was no face-to-face visits, there were no safety labs, and it's really a remarkably creative approach to a clinical trial in the midst of a pandemic, and to be able to complete this trial was remarkable, but also has implications for future randomized clinical trials. The one caveat that though is that SGLT2 has been shown to have a remarkable safety profile already. And whether you can conduct a randomized trial in this manner with no face-to-face, with no safety labs, if you didn't know that these compounds were already safe, I think one would have to pause and hesitate before extrapolating to novel agents where you don't have that strong background of safety already. But nevertheless, I think pointing the way that the possibility is very exciting. So with that, our time is up. Again, it's been my pleasure to be able to participate. I'd like to thank Dr. Sakata, and of course, finally, all of you who have been watching this commentary. Thank you for joining us, and have a